Stephen Heisler. I am a podiatrist in the Department of Surgery in the Division of Vascular Surgery. I became a doctor because I really like to care for people, and being a doctor is going above and beyond. And then even to elaborate on that is that then you become the surgeon as well, so that even in podiatric medicine is that you can do surgery and the medicine side and take people from start to finish. A podiatrist is two parts. It's a clinician and it's a surgeon. The clinician is the normal run-of-the-mill visit to like a family doctor, but focused on the lower extremity. When we look at the foot, I mean, obviously it's the foundation of, standing, walking, and running. And the best part about that is that there's so many things that you can do to help treat it and make it better. Patients that come to see me, they'll have wounds of prolonged standing, diabetic related issues. They'll also have regular podiatry, bunions, hammer toes, painful corns, nails, things like that. And there's a lot of conservative ways to treat those ailments that commonly occur every day. And the best part is that you can then, once conservative treatment has been exhausted, then surgically correct or fix deformities. And that's a nice part of just taking the patient from the beginning to the end, so that you can help them from conservative to surgical techniques the whole way through. The reason why I chose academic medicine versus private practice or group practice was the complexity of patients that you see at an academic center versus a private or group practice. And the team approach. Being within the Division of Vascular Surgery is exciting because we have a team. And then once we start to have more pathology, we come outside of our disciplinary groups, and then we need to converse with other specialties. And when you do that, you can have a much better outcome. The team approach is amazing at UNC because there's a body connected to the foot and the ankle. There's a person inside, that's connected to the foot, and there's so many other issues that could be dealt with that have to before you can go ahead and address the patient's ailment sometimes. And it takes a village to help a patient get better. I would want a patient, before they were coming to see me, to know that they're going to have someone who's going to listen and legitimately cares about what's happening with them, what type of pathology they have, and then be relatable, that they know that they can have an ongoing conversation with. I like that because it's a team effort between myself and the patient, because inevitably that will lead to a good outcome when we're both on the same page. I honestly thought that coming to UNC was a dream job, and I really felt that coming here was a phenomenal opportunity, and that I can utilize all the resources that UNC has to then deliver good patient outcomes and have fun doing it. I think a visit with myself is more thorough because I like to take the time to understand what the pathology is and listen to the patient's history of what caused it, so that what we can do is we can have a better outcome. And then what we can do is we can talk through it. And the interesting thing is I get a lot of aha moments. Oh, that's why it hurt. Or, oh, that's why I'm doing this or that. Okay, now that makes sense. And I feel like when you get to that point, you know that you're moving forward already before the patient even left the office. Because now they're educated. They know what's going on. And then therefore they get better.